Welcome to our next session in our Boosters and Beyond series, addressing key challenges. We've been going through the CDC's core infection prevention and control practices for safe healthcare delivery in all settings. Today, we have Mary Ellen Casey here to share with us standard precautions. And today's session is actually going to be a precursor to the next several weeks as we dive deeper specifically into the various different standard precautions. So we have a nice overview to go over today. If you're not familiar with who we are the IPRO QIN-QIO. IPRO specifically holds the federally funded Medicare QIO contract for the 12 regions shown here. IPRO specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the IPRO QIN-QIO. And with that, I'll pass it off to Mary Ellen.
Thank you very much. Well, welcome everybody and happy Valentine's Day. We always start with a COVID update, so just want to bring you up to date. Hospitalizations through February 8th are down again, thankfully 6%. We're seeing a 7-day average of a little bit under 4,000 cases. Bivalent booster update as of the 8th again. Over 52 million people have received the updated booster dose, and we're trickling up with adults 65 and older at almost 41%. The variants themselves as of February 11th are the same. The 3 that you see on the screen are the variants we've been seeing, the top 3 for quite a while now. So the good news is that they're not shifting and changing as rapidly as they had been. And I always take a peek at the NHSN data reporting for residents that are up to date with COVID vaccines, and we're creeping up slow but sure. Vaccination rate as of the end of January was at 51%. So thanks to all of you. This is the really hard work to get booster rates up. So with that, we'll dive into our topic for the CDC Core Infection Prevention and Control series we've been working on, and we're going to talk about standard precautions. And so you may recall years ago, they were known as universal precautions back in the caveman era when I first started practicing. And that actually focused more on blood and body fluid exposure and didn't include the environment or the spread of pathogens via healthcare workers. So how far we've come, right? So standard precautions is the basic practices that apply to all residents in all settings where care is delivered. And it's based on the principle that all blood and body fluids, secretions, excretions, everything except sweat basically is considered, could be considered potentially infectious. So the premise is that you are looking at residents with the idea that they may have something that you could potentially catch. So we're being cautious in all areas of care. There are also practices that protect healthcare personnel, and as I mentioned, that's sort of how it started. These practices also include preventing healthcare personnel and the environment from transmitting infections to other residents. So it really encompasses a whole lot more than just hand hygiene, which is, when I ask that question about standard precautions, what does it mean? People often say, well, you wash your hands, but it's so much more than that. These are the topics under the umbrella of standard precautions, and all of these topics listed here under standard precautions we're going to dive into in a little more detail over the next 6 weeks. But they include hand hygiene, environmental cleaning, injection and medication safety, PPE risk assessment, minimizing potential exposures, and reprocessing reusable medical equipment. So there's a lot under standard precautions that we sometimes don't think about. Hand hygiene sort of starts it all off. It's the very foundation of infection control, and there's going to be a lot more to come on this topic next week. But we know that the hands of healthcare workers are the most common mode of transmission of pathogens, and that many healthcare-associated infections are preventable with hand hygiene. I always think of it as the unsung hero, the low-tech member of the team, if you will. It really, really works. In this high-tech world we live in, hand hygiene is just so important and so difficult to get folks to comply with. But part of the core practices is requiring healthcare providers to perform hand hygiene per CDC recommendations, to use alcohol-based hand rub or washing with soap and water, and that's dependent on clinical indications. Part of those clinical indications could be where you're ensuring that healthcare provider is performing hand hygiene with soap and water when hands are visibly soiled. And the other part of it is that we ensure that supplies necessary, we have them for adherence and they're accessible. So it's not enough just to say, I have plenty of Purell, but if you have to make the healthcare provider run down the hallway to get it, it's really not encouraging healthcare workers to perform hand hygiene. And so you have to help them do the right thing, right? And make it accessible and easy to use. Environmental cleaning and disinfection is a huge part of standard precautions as well as all precautions, but I think of EVS staff as part of the infection control team. And cleaning is really indicated by the level of resident contact and the degree of soiling. And it can be required routine cleaning, it can be targeted cleaning. So you have your routine schedule of cleaning, but you may have a schedule for cleaning high touch areas more frequently, really important. Because organisms live on these areas that we touch. Part of routine cleaning is having prompt cleaning and decontamination of spills. So really important that that is taken care of immediately to prevent any transmission. And we don't often think of that. We think of, our regular cleaning, but that prompt cleaning when something happens is really important. Selecting EPA registered disinfectants, and again, this topic will get into more of looking at the EPA lists of products that you could use for your facility based on a risk assessment of what are the pathogens most likely we're going to encounter here. And all products need to have that microbiocidal activity, which basically means it's got to kill the pathogen that's most likely to contaminate the resident care environment. Important part of that is involving people in the selection of products, but also following manufacturers' instructions for proper use. And I remember starting in infection control, and we throw around so many acronyms that I heard the acronym IFU, and I thought, what are they? UFOs? What are they talking about? But an IFU is really the instruction for use for any product, and it may be something that you have on file. It could be paper, it could be online. The important thing is to have them, but make sure that the staff are aware that they're available and that they know how to access them. And they know what IFU stands for, because it would be Murphy's Law that the surveyor would come in and not ask the infection preventionist or administration, who might know what it is, but the staff said, do you know where your IFU is? And they may not have any idea what they're talking about. The IFU has information on dilution, contact time, storage, safe use, and disposal. So all really important. And in some cases, if you find you're using a product and the IFU is limited, or you can't find it, or they don't supply one, it happens less and less, but it still happens. Then the second best thing is to use the best available evidence that you can get and carefully consider the risks and benefits of that product. And we included in the slide deck some great resources, the environmental cleaning procedures through CDC and the guidelines for disinfection and sterilization. So they're both good resources to have regardless of IFUs, and we've included that. The other thing we hear an awful lot about is terminal cleaning, and again, that is part of environmental cleaning under the umbrella of standard precautions. So people often think, what the heck is terminal cleaning versus routine cleaning? Terminal cleaning is defined as a procedure requiring thorough cleaning to ensure that an area has been cleaned or decontaminated following the discharge of a resident with an infection. It could be some sort of alert organism that you're aware of, or communicable disease. It may not even be that they're being discharged. It could be that they're moving rooms. And the idea is to clean that room above and beyond what you would clean with routine cleaning to ensure a safe environment for the next resident. There's lots of studies out there that, particularly with C. difficile infection, with the spores, they're so hardy and so stubborn that oftentimes if a good thorough cleaning isn't done when a patient who's had it is discharged, or a resident that's discharged or moved to another room, then that next resident coming in is more likely to contract CDI from the spores that are left behind in the room. So again, really important part of your cleaning process. Injection and medication safety is another area of standard precautions, and again, sort of born out of universal precautions when blood and bloodborne pathogens were really coming to light. And so injection safety protects not only patients and residents, but it protects healthcare workers as well. There have been numerous accounts of outbreaks due to injection safety breaches. You might have read, I've read several, but I can recall one in an outpatient endoscopy center. I cannot remember the state it was in, but they were practicing safe injection procedures, and they were using an IV bag of normal saline to fill syringes, to mix medication, but it was one shared bag for the day. And the tragic consequences of that were there were over, I think, 50 patients that contracted hepatitis C as a result of that. So there's lots of examples of what can happen when you breach safe practices. And they can occur if you reuse syringes, if you have a contaminated medication vial that you're using for more than one patient, use of a single dose vial for more than one patient. A lot of times you hear these things and say, how can that be? But if you don't know these safe practices and you're concerned about cost, and that has been cited as a reason, then you think that there's nothing wrong with doing that, but that's not the case. Drug diversion is another area of outbreaks, and this has sort of come to light. I've seen more and more in recent years where we've seen outbreaks of Hep C in particular because of drug diversion by healthcare providers or employees. So really important part of your medication safety program. And the other piece of it is making sure that you're using aseptic technique when you prep and administer injections. Performing hand hygiene is sort of a given with any type of procedure that you're doing, and certainly something surveyors will look at. And drawing up medications in a designated clean medication area. It could be really a clean area, but you might be doing it next to a sink, and so there could be some contamination with water or splashing. This kind of sticks out to me because our facility was cited for this very reason. We had a very small medication prep room. It was clean. It seemed fine from our perspective, but the surveyor was concerned because the counter was so small that the faucet and sink was right next to it. So the concern that there might be splashing, and faucets do have organisms in them that are latent, kind of hang out in faucets. So we got dinged on that. So the recommendation was to put a plastic partition between the sink and the counter space, and that satisfied them. So it's just something to think about when you're preparing what the environment is like around you. Lots and lots of resources on safe injection practices. I just highlighted the one needle, one syringe, only one time. That's the one and only campaign through the CDC. It really speaks to using needles, syringes for only one patient, infusion sets, one patient. I'm sure all of this is based on things that have happened, and you think, well, that, we would be doing that, but there have been breaches where this is really spelled out in these campaigns. And trying to limit multi-dose vials to a single resident, and that's hard sometimes depending on medication, but best practice is that you limit that, even though it's a multi-dose, to just one person. When we talk about PPE, part of standard precautions is doing a risk assessment on PPE. So again, standard precautions, you think, okay, hand hygiene, I'm going into the room to do what I need to do. But remember that you have to go in with the premise that the resident might have something you're not aware of. So there's a few things. Healthcare providers need immediate access to PPE. They need training. You just can't see it and say, okay, I'll use this, and not know how to properly put it on and take it off, and think about what pieces of equipment you need depending on the nature of the resident's interaction. What are you going to be doing when you go in there? And what's your potential risk for exposure to blood, body fluids, or other infectious material? As an infection preventionist, I'm never going to say, oh, too much PPE. I'd rather see you overcompensate and protect yourself than say, well, I don't really need it. So that's the difference, that PPE isn't eliminated with standard precautions. It's part of your risk assessment going into the room to determine what you need. It may be gloves that you need, depending on what you're going to be touching when you go into the room, whether it's a resident, whether it's equipment. So wear them, gloves and gown, when it's reasonably anticipated that you might be exposed. A gown is important really to protect not only your skin, but your clothing, so that you're not the means to transmitting whatever that resident may have to the next resident. So it works in a few different ways. One of the things that I feel is really underutilized with PPE is protective eyewear. We've seen a lot with face shields, and with the pandemic, I think people have been more conscientious of using this kind of PPE. But in all reality, especially historically, when I look back at my years as an employee health nurse, and I've had to investigate exposures, a lot of times when it's a splash exposure, and I'm sure you can think of examples, you're rushing, you're trying to get things done, you're emptying a Foley catheter, and it splashes just the right way. It's Murphy's Law. And the first question I ask people is, did you wear goggles? And they just don't. Goggles are not intuitively thought of when you're going into a room, but think about it. If you're doing something where a resident has an IV, or you're removing an IV, or I think of catheters because they're usually the ones that we think of often that we get a splash from. But even doing a dressing, things happen and people move, and you have the potential to have that in your eyes, nose, and mouth. And while the risk is probably lower than a needle stick, the anxiety is just as high. People are worried and concerned. So again, it's just really thinking about the things you might need to go into that room. Removing and discarding PPE is just as important as putting it on. And so we've gotten a lot of questions. I think sometimes interpretations of what it means to doff PPE is, it's different depending on who's reading the regulation. But according to CDC, if you're removing and discarding PPE other than an N95, and this was where the confusion lies sometimes, if it's gown, gloves, face shield, eye protection, once you complete the task, you're supposed to doff it inside the room with a trash receptacle. Ideally should be right inside that door. You doff it, you go outside the room if you have an N95 mask on, and then you doff the N95 in the receptacle right outside the residence room with the door closed. That's the CDC recommendation for doffing PPE properly. It doesn't all come off inside the room, it doesn't all come off outside the room. So just something to be mindful of. And this is spelled out in the CDC core practices online. If you are looking for the specifics, they really spell it out about that particular process. When we talk about minimizing potential exposure, the first thing you should really think about is, do you have a system, or have you implemented a system for early detection and management of potentially infectious residents? So at the point of admission is where I'm thinking. If you can have that knowledge as they're coming in the door, it's going to save a lot of angst. And do you have that? Is there some sort of alerting system in your health record management? Is there communication that works well for you when residents are coming from hospitals and there's that the transfer? Is that communicated? I know sometimes that's challenging, that you're not always getting the information about maybe the resident is coming in with MRSA colonization, as an example. So to know about it before they even walk through the doors is really important. And of course, once folks are in, a lot of this has really been elevated with COVID. But at the same time, I think we're so tired of this, we forget that managing exposures is just part of infection control regardless. So using respiratory hygiene and cough etiquette prompting residents and visitors about respiratory etiquette and performing hand hygiene, which is challenging because you have so much to do, and yet we're still teaching people and acting as resources as they come in. But hand hygiene stations are really important. If you have those where there's tissues, masks, hand hygiene supplies, and instructional signage at different points just to remind people. Obviously, if possible, separate residents with respiratory symptoms as soon as possible. Even if you can manage at least that 6-foot distance is really going to help. And then reprocessing of reusable medical equipment. This is really important as part of standard precautions. And again, I think it's an area of scrutiny that we've seen over the years, more so just with the amount of equipment that we use. But we should be cleaning and reprocessing reusable medical equipment prior to use on another resident. You may do disinfection or sterilization depending on your facility and what type of procedures you're doing. But cleaning and reprocessing things like blood glucose meters, other point of care devices, blood pressure cuffs, so important, oximeter probes, we don't think about it sometimes just in our haste and trying to get things done, that these need to be cleaned in between patients. Patient lifts, really important. Again, think of them as equipment where fomites live. They're vectors for organisms that are really sneaky and stay put for a while without proper cleaning. And then again, maintaining a separation between clean and soiled equipment to prevent cross-contamination is really important as part of standard precautions. I looked at the CMS reg for infection control overall and just kind of looked at their verbiage for standard precautions in particular. And really, it's all about policies and procedures. At a minimum, that they should define standard precautions to prevent the spread of infection, that you're following evidence-based practice, and you can explain their application during resident care activities. Some people are very detailed they have policies for every type of precaution, hand hygiene, nail policies, jewelry policies. So you may have that, and it's important when surveyors come in, they see that, you're setting that standard. CMS defines standard precautions. It's information overload on this slide, but if you look at it, you can see that everything that we're talking about today and in the coming weeks are part of what CMS also defines as standard precautions. So they're really following the CDC's definition. And what do surveyors look for? Well, these are trends, certainly from you folks that have talked to us about some of the trends you're seeing has been very helpful to help your colleagues. But the surveyor is going to look at policies and procedures that define standard precautions and prevent the spread of infection. And they're going to ask staff about how they apply standard precautions during resident care activity. So verbalizing and demonstrating is key, that they're following hand hygiene practices consistent with standards of practice, that they're including residents needing assistance with hand hygiene. We've heard that as well, that they're looking at how are residents washing their hands and do they need help and are they getting help? Really important as well, and very difficult. PPE, that the staff can identify types of precautions and the appropriate PPE that they're using and that it's readily available, it's near the resident's room. Linen is a huge piece of standard precautions, really how we handle it and store it, that we're not shaking it, that we're covering it. So all of those things is part of linen management to prevent the spread of infection. And that F880, that catch-all tag for infection control, focuses on ensuring that long-term care have an infection prevention and control program. And again, these are sort of the hot topics that we've heard and seen that often get cited. And they're looking to see that you're verbalizing and demonstrating practices such as the things that we mentioned. Even dietary practices I included because they're going to be looking to see how staff are managing their hair as part of food prep. That's just one area that they mentioned, but there's certainly more. So that's something to consider as part of your standard precautions policy. Wound care and dressing changes, a hot topic in terms of just the whole wound care process. And when you're doing dressing changes, are you changing your gloves and washing your hands in between? That has been huge. And so what happens is if it isn't verbalized and demonstrated properly, then they start digging. They might start asking you, well, when was the last time you had some infection control training? And when did you go over wound care or that kind of thing? So it's sort of, there's a domino effect to it. And certainly infection control training should be done at a minimum of annually. But if you're seeing trends or you're seeing surveys where you're seeing some of these issues come up, it might help guide infection control training more often. Administrative policies, they are part of the survey as well, that administration needs to incorporate infection control into resident employee safety processes. How they do that may differ facility to facility, but OSHA logs are one example, that you keep OSHA logs. Do you have an employee illness policy? Those kinds of things that they're looking to see that the facility is incorporating infection control at every level, not just with resident care, and that they're committing resources to the infection control program, whether it's financial or staffing. And we know how important that is with all the regulations coming down the pike. So that ends the portion about standard precautions, but I did want to end, and folks may have seen this just came across my email this week, and I wanted to share with you that the American Healthcare Association has joined forces with the Association for Professionals in Infection Control, or APIC, to set up a long-term care infection prevention forum, which I think is really exciting and long overdue. I screenshotted my email, and unfortunately the link here, the 3-question survey, I took it. And so if I click on it, it says I've already done it. So that doesn't help you very much, but we did include the link to the Survey Monkey. It's basically just giving your name and email address if you want more information about joining it. And also the email contact is listed as well. So more to come with that, but hopefully it will be helpful for folks in their infection prevention duties. And I think with that, we've listed resources. All the resources I talked about and a few extra ones through the CDC are really, I can't stress how important they are with all the information we have to remember. It's just nice to have the reference to go to. So with that, Josh, I don't know if I'll stop my share.
Like I mentioned, today was a nice high-level overview over the standard precautions, and we're actually going to be diving each week into them more specifically and thoroughly. As Mary Ellen mentioned, next week we're going to actually be diving into hand hygiene more. So be sure to be on the lookout for that. But we'd love to hear from you if you thought that the presentation was helpful, or if you have any other questions or comments you want to add for today's session, that'd be really appreciated.
I was just peeking at the chat, and I noticed about the PPE fatigue. And I hear you. It is, and many facilities are getting cited for not properly donning and doffing. So in the facility I was at, there was and there continues to be PPE fatigue.